Okay, hi everybody. Sorry we're a couple minutes behind. It's my fault. And I'm pleased to introduce our next speaker here. This is Dr. Lynn Martin. Dr. Martin is recently retired from serving as medical director of continuous improvement and innovation at Seattle Children's Hospital. He's also emeritus professor of anesthesiology and pain medicine at the University of Washington School of Medicine. His recent research interests focus on quality improvement, patient safety, and operative outcomes. And the topic he's going to be sharing today is an important one, and I'm pleased you'll be here to enjoy it. Dr. Martin, I'll turn it over to you.
Thank you very much, Matt, for that introduction. I want to start off by quickly thanking the organizers of the Lean Global Conference for this opportunity to speak on a topic of great passion to me. For the last 20 years, I've dedicated my professional career towards helping physicians improve their clinical practice to provide better outcomes to the patients and families that they serve. So it's a topic that I've spent many months and years working on. In medical conferences, we're required to call out any potential conflicts of interest. So I need to disclose that after retirement, I've become the chief medical officer for Adaptix, which is a software healthcare software data company. And much of the data that you'll see in this presentation was derived by Adaptix. Working within healthcare, it's a very different type of industry from many others. It's a service industry, but it's a service industry that is very resistant to change. And one of the foundational reasons why that is that it's a physician-driven profession. And physicians from day one in medical school are really taught and cultured to value their autonomy. They are responsible for the care delivered to their patients and families. They also feel like they win into medicine many times because it's not a business, it's a profession, and money is not a primary motivator or a deciding factor when you're taking care of patients. Similarly, when using data, it's, in their opinion, difficult to judge a physician's performance simply based upon the data that is generated. However, I've learned over the years that the perception that many physicians have regarding standardizing their practices, their term they like to use is cookbook medicine, and that it feels like it is simply following a recipe and very constraining, which in actual fact, what following protocols really does is it really allows clinicians to first minimize variation brought in by variations in physician clinical practice, creating a more standard and measurable, reliable outcome. In essence, of creating a bigger signal to noise ratio. When you decide you want to make one change to that protocol, you're much more likely able to see whether that change is a good change or a bad change or no change. And doing that over and over iteratively over time, the goal is to continuously reduce the variation brought in by professionals until it's eliminated, ultimately then just leaving the variation that arises from the patients that you encounter in your clinical practice. You have to learn and work with physicians to help them understand not only the value of standardizing their clinical processes and practices, but how do you go about doing that? And principle among these is don't tell them how to improve their clinical practice. Engage them in a conversation and have conversations about the benefits of standardizing your practice, and then working with them to come up with that standardized practice. The first place you go after engaging in that conversation is the data. And up until recently, it was very difficult as a physician to get your hands on your individual practice data, let alone your group's practice data. Now, with emerging tools, it's really much easier to get snapshot of real world data pulled from your electronic medical records. And ideally, then you're able to identify best performers or practitioners within your group practice that you go and have conversations with and actually observe their clinical practice to try to glean what it is that they're doing different and better that separates them from their peers and drives the better outcomes that their patients and families are able to benefit from. Whenever possible, it's always nice to see if there's clear evidence in the medical literature, published research that shows that there is a better practice. Unfortunately, in medicine, less than 10% of the time is there clear evidence from clinical research protocols that clearly define that a protocol or a process is better than others. So more often than not, the clinicians are then left to look at their own data and have conversations and develop hopefully a group consensus about what's the best direction, the best practice that they want to test and create as their next standard. Regardless of how they achieve that standard practice, it's always, always critical to make it easy to follow that new protocol, and ideally make it easier to follow the new protocol than any old protocols or any non-standard protocols. Therefore, the physicians are, in essence, driven down this pathway of following the standard practice unless there's a real clinical reason, primarily brought by a patient or family, that drives you away from that clinical protocol. You can deviate from the protocol, but you really should have specific clinical indications and steps that need to be taken to before you switch. It's also really, really important when you're trying to standardize your clinical processes. It's most effective when they're developed in local, small, little work groups, and then the process to follow that new standard practice or protocol is embedded in the electronic medical record with electronic alerts and data to help facilitate the physicians, reminding them to follow the clinical practice and showing them in real time what their outcomes are when they follow those clinical practices. When you go and observe a physician or a clinical process, most physicians are not trained in lean methodology, and so you kind of have to teach them how to go and observe a clinical practice. So first and foremost, you want to just clearly delineate what are all the steps in the procedure that you're documenting. Similarly, once you know what the steps are, you want to note the sequence of steps and the variation of the steps and the procedures that occur along the way. And then ultimately, you draw first a current state process map, which catches all the steps in their variation and all the sequences in their variation. Then you want to draw a process map of what might be your target next condition, the next step or improvement, the next single standardization step that you want to take along the way. Which one of the steps in the sequence do you want to resequence, or which one of the steps do you want to modify? But that would be considered your target condition, and you're doing that over and over and over until you reach your ideal state, which is when you have a fairly detailed document that defines the standard steps and sequences that each and every practitioner would reliably and consistently follow. It's also really, really important when you go to get data on performance for physicians and the group. The ideal best practices defined by the Health Institutes for Healthcare Improvement is shown here. It's a statistical process control chart. In essence, you're tracking data over time, and you're able to delineate what's the mean, what's the upper and lower control limits, and you have statistical methods that help you distinguish or differentiate what's random, normal variation within the system, and what's a signal, what's a significant perturbation to the system, either for the better or for the worse, that shows you that the intervention that you've just tested is successful or not, or the evolution or devolution in the standard process, the no longer following the standard process, may be showing you a signal that now the performance is not as good as it used to be. So SPC charts are foundational in our process for helping us define data and follow our outcomes. And you'll see numerous representatives of SPC or process control charts going forward. It's also important to just take a moment and really understand that, better understand what we mean when we talk about consensus. Most people think of consensus as a vote, and ideally you get a unanimous thumbs up. Everybody says we really like it, but in reality, that never happens. So if you get a group, particularly a group of physicians together, you're never going to get unanimous agreement that they all say this is something better to do. The next most common suggestion for consensus is a simple majority vote. You got a group of 10 and 7 of the 10 vote affirmative, and everybody says, okay, now we have a consensus. Well, in actuality, those 3 who voted no would say, no, this is not consensus. I am not satisfied with that outcome. So to try to get to consensus, we use the tool that's illustrated here, which helps us get to a solution. And the solution we're looking for is getting to a decision where everybody can say the solution is acceptable. I might believe in it, but at the very minimum, I can support it. And most importantly, I'm not going to oppose it or fight it or not follow it. So we rate our support for a new process or a decision from a scale of +3 to -3. Obviously, the pluses say this is a good decision and I'm going to support it. A 0 is a neutral. I have no strong opinions, but also implies I'm going to support it. A -1 technically means I don't think it's the better of the choices, but it's still something that I can support. So really, non-consensus occurs when people vote either in a -2 or a -3. When you have a situation where you have members voting a -2 or -3, it's really important to take the time to hear their opinions. Why is it that they feel like this is a decision that they should not or can't follow? More importantly, rather than just listening to them and listening to their anecdotal opinions, we really now say, okay, if you can't follow us, then show us better. Show us a better solution. And what a better solution has to be based upon is data and medical evidence, published evidence in the literature. If you can't bring data, you can't bring publications from the literature, then you're not going to win the argument. And over time, usually when you insist upon someone standing up and defending their decision and bringing in their own best practice suggestions, most of the time those members will ultimately, I'll say, acquiesce and fall in line and say, okay, I might not agree with it, but I'm a -1, I can support it and I can follow it. And that's ultimately the goal, is you just need to get everybody on board so that they're not subverting or undercutting the process. There are numerous benefits to the challenge of standardizing your clinical care. It not only, as I've alluded to earlier, reduces provider-generated variation in the process, and there's a surprising amount of variation in the clinical processes that comes strictly from clinicians. In fact, I would argue in most hospitals, the majority of the variation comes from clinicians. And that variation leads to a lot of very bad things: confusion, chaos, errors, and bad outcomes. So by standardizing your practice, it creates greater efficiency. And so there's less waiting as you work through the processes. It's not only less waiting for patients and families, it's also less waiting for the faculty and staff working in the medical facilities. Standardization also dramatically facilitates collaboration and teamwork. The whole team knows what the standard practice is, and they quickly start to synchronize their practices and help support each other. So there's this less chaos, much less frustration as you work through these clinical processes. There's also much greater reliability in the processes. So everybody knows what the standard is, everybody's following the standard, but even more importantly, when the standard is not followed, it becomes visually clear very, very early in the process. And so when someone starts to not follow the standard practice, you don't yell at them. You just quietly say, it appears we're not following our standard practice. What's driving that decision, and how can I help? So it allows you to identify the potential for error earlier and intervene earlier before that error possibly reaches the patient and causes a worsening in outcome. It also is because of enhanced operational efficiencies, typically is able to significantly reduce costs in care delivery. And ultimately, all of these combinations align quite closely with the 6 domains of quality within healthcare to generate better outcomes. But most importantly, once you've standardized your practice, you now have that stable foundation for continued learning, continuing your process improvement, and continuing to do further PDSA cycles of improvement to not only create that standard, but now make that standard better. And you're able to do that with a much better signal to noise ratio. So how do you go from a standard practice to a best clinical practice? It really boils down to, in my mind, the use of real world data, having your ability to get your hands on real time, within a day, outcomes and process measures as the system is working. It allows you to test new protocols in real time and reject the hypotheses if you see the outcome is not better, or in fact getting worse. You can end the trial very, very quickly. And if you see it's headed in the right direction, you can continue that trial until you reach a statistically significant improvement in performance that says, okay, this is definitely better, and this is now our new standard practice. What I'd like to do over the next series of slides is now really focus on our surgical practice at our children's hospital here in Seattle, and how we've utilized SPC charts and this fundamentals of lean improvement to drive out the use of opioids, very potent, the most potent pain medications, as routine part of surgical care. So what I want to talk about first is the very first case study where we attempted this. This is for adenotonsillectomy. That's the most common surgical procedure there is at a children's hospital. And at baseline, before we had access to real-time data, we worked really hard. We were able to test a new protocol about once every 2 years. So we first standardized our practice in 2012. We get to 2018, and it's now time for our third iteration on our tonsillectomy protocol. But now in 2018, for the first time ever, we have real-time access to data. And so we're hoping that we're going to be able to accelerate our rates of change. The blue is our baseline measures of two primary outcomes. The top graph is our opioid rescue rate in the recovery room. In other words, a patient arrived in the recovery room in sufficient pain that the nurses decided they needed to treat. And the bottom graph is the maximum, the highest pain score recorded in the recovery room. 0 being no pain, 10 being the worst pain I've ever felt. And you usually divide them from 0 to 3 is considered mild pain, 4 to 6 is moderate pain, and 7 to 10 is severe pain. So at the start of the green period, I, as the physician, the anesthesia leader, asked the team to not improve either of these outcomes. I simply wanted to reduce the cost of our anesthetics. We were using some very expensive medications. And so I asked the team to come up with alternative medications that would reduce the cost and hopefully keep pain scores and rescue opioid rates in the recovery room the same. So you can see the first PDSA cycle we went through was not successful. It had an increase in pain scores on the bottom graph and a significant increase in the rescue rate of opioids. The good piece about it is it had significantly reduced the opioid dose. So the next protocol, PDSA2, we literally eliminated the opioids and increased the dose of a second medication. And you could see that the rescue rate dropped some. The pain scores were still a little bit higher. So the third PDSA, we added an additional intravenous non-opioid pain medication, and we got our rescue rate and our pain scores back to baseline. Now with no opioid medications for one of the most painful operations we do. We actually publish those medications, and usually in medicine, when you finish a protocol like that and you publish the results, you move on and you forget about it. And then what happens is the protocol slowly erodes over time. We do not do that. We continued our efforts to get better. In fact, I set the target that you see there in green. We were not satisfied with our rescue opioid rate. It was, even at baseline, still hovering around 20%. So we set a target. We wanted to get it down to 10% of our patients requiring an opioid dose in the recovery room. And it took many, many PDSA cycles or trials, but ultimately we now have the rescue rate of morphine down under 10%. You can also see visually how much more rapidly we're able to run through the cycles, the cycles of improvement when we had real-time access to the data, because we could very quickly reject a hypothesis like PDSA1 was literally rejected after 3 days. We knew it was not going to be better. We stopped the trial immediately, and we started planning for what's the next one we're going to do. And then we usually waited sufficient time to be certain that we either had a clinically significant signal for better or no change before we went on to the next cycle. Also, while you're looking at your primary outcomes, it's also important to look at balancing measures. One of the things we worried about with some of the newer medications is they have a sedative side effect. So we wanted to make sure that we were not prolonging recovery room stays. And we have, as a quality measure, prolonged recovery is defined by greater than 2 hours in the recovery room. You can see that rate was constant, with the one exception when we were in the middle of the COVID pandemic, and we actually had a number of patients come to our surgery center for planned admissions. And so that one point is artificially elevated because of COVID. The bottom graph we were looking at was postoperative nausea and vomiting. As we eliminated our opioids, not surprisingly, and pleasantly, we found that our rate for postoperative nausea and vomiting significantly decreased as we eliminated our perioperative opioids. So you can see here now, at current state, All of our indicators, quality indicators for tonsillectomies, are now reached green goal state. Our pain scores are stable. Our rescue opioid rate is below our target of 10% and has gone through a 2 times improvement. The rescue treatment for postoperative nausea and vomiting has also been reduced by 4 times from where it was at baseline. And our 2 balancing measures, prolonged PACU stay and unplanned hospital admissions, also remain stable. As we did this tonsil work, we started to then realize, getting rid of opioids for one of our most painful procedures, if possible, we might be able to do it for other procedures. And this was in the context of the opioid epidemic that we've been struggling with here in America, in particular, for the last decade or so. So the team was very eager to shift gears and consider expanding this to other surgical procedures. It makes sense since opioids are nearly ubiquitous in the US. 90% of surgeries, patients receive opioids. There's a long list of common side effects, and near 6 to 10% of patients who are opioid naive end up becoming chronic opioid users and contribute to the opioid pandemic. So the group decided we wanted to pursue a strategy to continue reducing or eliminating perioperative opioid use. So these process control charts here, you can see this was the tonsil experiments on pain scores. Here, we now have stop opioids for all of our ambulatory surgical procedures. Pain's stable. You can see that the postoperative nausea and vomiting rate has dropped even further as we continue to reduce opioids for these other procedures. You can see that our balancing measures remain stable. Length of stay in the recovery room, length of our total anesthesia time, and then the rescue rate for nausea and vomiting. With the success we had on the day of surgery, then our surgeon says, we could probably do a better job with opioid stewardship after the surgery, after the patients go home. So our ear, nose, and throat surgeons looked at the average number of doses of opioids they sent home prescribing to their patients, found it highly variable with an average of about 12 doses. And when they contacted their families, they actually found that about half of those doses were really used. So they created their first standard, which was 8 doses, and found that the protocol was followed quite nicely. Here with this S chart, you can actually see a significant reduction in the standard deviation, visually showing the reduction in variation in the process. And with PDSA cycles, they reduced it from 8 to 7 and now down to 6. So they've literally had a 50% reduction without any increase in pain, postoperative phone calls, hospital readmission rates. With the success that our ear, nose, and throat surgeons had, then our other surgeons joined in and went through a similar process and have been able to demonstrate a 30% reduction in their opioid administration postoperatively for ambulatory surgeries. These are surgeries where the children come in from home on the day of surgery and go home on the day of surgery. So now we have what we like to call an opioid-free ambulatory surgery center. We started out with 70 to 80% of our patients receiving opioids on the day of surgery, and now at least intraoperatively, it's down to 0.3%, and it's about 9% in total if you count the PACU patients as well. With the success we had in the ambulatory setting, it's not surprising to see clinicians say, this works so well, there are clearly patients in the hospital that might be benefit from the same protocol. And so the clinicians started then experimenting in a controlled manner, applying the same protocol to patients who require postoperative admission in the hospital in a very selective manner. And you can see over time, we've gone from 80% of patients receiving an opioid to now we're down to 30% of the patients receiving an opioid during the anesthetic itself. We've also looked closely for specific cases where we can demonstrate that that practice has been beneficial. Here is one case. Again, patients who are undergoing a tonsillectomy, there's a subset of them that are having this procedure because they have a disease complication called obstructive sleep apnea. In essence, the big tonsils cause obstruction of the airway while they're sleeping, and it increases significant risk, not only for medical complications like heart failure and pulmonary hypertension, but it also has significant risks with anesthetics. So once that was recognized and sleep study standards were created, there were national organizations that basically stated that an apnea hypopnea index, AHI of greater than 10, was defined as severe obstructive sleep apnea. Patients with AHIs greater than 10 were required to be hospitalized post-operatively for their admissions. So we implemented that practice in 2015. In 2018, when we adopted our opioid-free practice, in collaboration with our surgeons, we loosened those criteria, raised the AHI threshold up to 15 for severe obstructive sleep apnea, and we monitored our patients very closely. We found that we were able to avoid over 50 hospital patient days per year, and we saw no increase in the complication rate. And just recently, just in the last month, we've now increased our AHI threshold to greater than 20. We've also found for appendectomies, this is the most common emergent surgical procedure in the pediatric population, that this is another surgery that aligns nicely with the ability to do opioid-free anesthesia. And you can see in the top graph, we've gone from nearly universal administration of opioids for appendectomies to now it's down to about 10% of patients receiving an opioid. With that transition, patients who get an opioid-free anesthetic now have a 1.2 day shorter hospital length of stay. This has significant implications for an institution. In our institution case, we save over 500 patient days per year by following these protocols, and particularly during the COVID pandemic, those freed up hospital days were really critical because hospitals were running at 100% census routinely. And so every day you saved was potentially another life saved. So in summary, I'd like to say our cumulative results since we pursued this pathway of creating opioid-free anesthetics and minimizing postoperative opioids, we now have completed over 112,000 surgeries since January 1 of 2016, and over 56,000 of those surgeries have been with opioid-free anesthetics. In our ambulatory surgery center, it's in essence nearly 100%, 99.3%, and it's now 65 to 70% in our hospital. I can tell you those numbers there on this slide, those are from yesterday. I literally pulled them off our data from this morning. So this is real live data, and that's what real world data allows you to be able to do. With this practice, we've now been able to save over 2,700 hospital patient days on this list of surgical procedures that I have listed down here. And that's a somewhat of an estimate, but the number's probably higher because there are other procedures that I just didn't have time to look at. So in closing, what I'd really like to say is that physicians can learn from their clinical practice, and it's much easier for them to standardize and learn from their clinical practice when you give them access to their own data and their group data. The use of democratized real-world electronic data is very engaging for the staff. It creates a platform for active conversation and significantly accelerates the rate of improvement that you can achieve in a medical practice. And even the small iterative changes that you're pursuing, if done rapidly and over a period of time, can lead to large and meaningful improvements in clinical practice over time. I'd really like to thank you all for, again, the invitation and opportunity to share our results. On this last slide here, I've left my email. If you have any questions, I'd be more than delighted to answer questions that those have. Thank you very much for your attention.
Well, thank you so much for the presentation, Dr. Martin. Hard to think of a more important issue these days with what you're seeing out there, and just want to thank you for the amazing work you're doing to try to solve what seems to be an intractable problem. We did go a bit over time, so we don't have time for Q&A, but thank you again for joining us here for the event, Dr. Martin, and we'll see you all in another session.
Thank
Thanks so
you.
much.